The ringleader.
Thousand copies per milliliter of blood. But if after 6 good months, you still realize that your viral load is more than 1,000 copies per mil, especially when the patient is adherent, obeying all the rules of the game, then we say that virologically, the treatment has failed. Because one of the key goals is to reduce viral load, even send it to undetectable limits as long as possible. And here is the case: after 6 good months, we are still having high loads. In fact, if you want to switch from one stage of the treatment to the other, first line to second line, or second line to third line, or third line to salvage therapy, you would actually base your argument on virological failure, not on immunological failure nor clinical failure. It is based on virological failure that treatment options are modified, are changed from one level to another level. But we are still interested in your level of CD4 count, because that is again one of the goals. As the viral load decreases, we expect the CD4 count to increase. So if we say that immunologically, CD4 cells are your immune cells, you have failed, then it means, according to the age categories, for example, if you are a normal adult and persistently we expect the CD4 count to go up, but you, after say 6 months or all through when you started your management, you always have your CD4 count still below 200 cells per millimeter cube. So disappointing. And it means that you have failed when it comes to immunology. Those who are younger than 5 years, we used percentage as per their CD4 cell count. So if it still remains below 10% of your immune cells, then it means that you are still not doing well. And those who are older than 5 years, if theirs falls below still 100 cells per millimeter cube, after being initiated on the drug for about 6 months or more, we are not getting the target, because this is not part of the target that we set. We rather set the target that we want the CD4 cell count to increase. Then the third one is clinical failure. As the viral load decreases and CD4 cell count increases, it is expected that opportunistic infections will not appear or reappear, because by that time you have regained immunocompetence. But if still you are on treatment and you realize that you are still having reoccurrence of, for example, the problems classified under the WHO classification 3 and 4, you are still having TBs coming in, Kaposi, sarcoma, excessive weight loss more than 10%. All these things are there. Cryptococcal meningitis, histoplasmosis, what have you. And it means that clinically, the treatment has failed. Because if your CD4 cells are increasing and the viral load is decreasing, we expect you to become immunocompetent. And therefore, clinically, you should be stable. You shouldn't be having repeated infections here and there. So these are the three categories, and it means that clinical failure under HIV management. Now, common opportunistic infections that will normally come in as your CD4 cell count decreases and viral load increases. Normally, common ones include TB, toxoplasmosis, herpes simplex and zoster, cytomegalovirus infections, cancerous states like Kaposi, sarcoma, candidiasis, especially oral one, and even vaginal, vulvovaginal, leishmaniasis, and various types of systemic bacteria or fungal infections, septicemia. We will try and look at some of them, but there is a problem, especially when a highly active antiretroviral naive patient, somebody who has never been initiated on heart therapy on his or her first presentation, comes with the HIV positive test plus an opportunistic infection, for example, TB. Normally, it becomes dicey because there is this possibility of an immune inflammatory response called immune reconstitution inflammatory syndrome, IRIS. It is possible based on the way the treatment is initiated when the person who is heart naive presents with an opportunistic infection at the same time. This normally happens when immediately you start managing the two, the OI. Let me use TB as an example. So somebody comes with TB and HIV. Then the person comes immediately. Note that the TB is active now because the immunity of the person is down. Hence, the opportunistic infection, TB, has set in. Once the person is able to regain immunity, around the time that you still have substantial count of the TB load, then the person now is immunocompetent in a way, and therefore the person's immune system will mount an inflammatory attack to the TB. Likely, you may lose the patient. The patient may not be able to withstand the excessive inflammatory response. In any way, HIV is not an acute infection. It might, as in maybe been there for a very long time, 10 years, 15 years, 6 years, 4 years. So why do the treatment in a rush? So the strategy is such that to avoid this kind of reaction, preferably attack the opportunistic infection here, for example, TB. Try and reduce the TB load. Then you start the initiation of the heart so that by the time the person regains immunity, then the TB load will be so low that even the reconstituted immunity of the patient can even decide to ignore because the quantities are very low and therefore you are not going to get the excessive inflammatory attack. But if you start giving the heart and luckily the person regains immunity whilst you have substantial quantities of the TB, then of course, the person's immunity is going to mount a very strong inflammatory response. There may be excessive shock, and your patient may not survive. And therefore, for TB, for example, you are likely going to do, especially in HIV patients nowadays, you do it for 8 months. 2 months intensive phase, where you use 3 drugs for the TB, then 6 months continuous phase, when you use preferably 2 drugs. So you start, and from 2 weeks to about 8 weeks, you can now initiate. By the time you initiate the heart, to the time that the person may regain enough immunity, then by that time, you've almost gone past the 2 months intensive phase of the TB. And that is expected to reduce the TB load substantially. Therefore, even if the person regains immunity along the line, the presence of the residual TB would be ignored, and therefore the inflammatory response, even if it will occur, will be minimal, and your person will not have any problems. We have 2 main forms of this kind of reaction. We have the unmasking iris and the paradoxical iris. Unmasking iris and paradoxical iris. What are these? So the unmasking one, you are unmasking something. It means something is hidden. So you want to unmask it. So normally there is a flare-up of an underlying condition that was previously not diagnosed. So you missed the diagnosis of the OI, and therefore you didn't even know that there was any OI. So straight away you started managing the HIV, and unfortunately, this time the person regains the immunity and then will react to the presence of the OI. And therefore the person, even though you are giving HIV medications, the person's health deteriorates because of this reaction against the underlying or hidden opportunistic infection. If this deterioration occurs as a result of missing the diagnosis of a certain OI at the time that the patient presents with HIV infection, then it is called an unmasking type of iris. It was there, but you didn't know. So the treatment has now unmasked the OI because you are now getting an immune response against it. Then we have a paradoxical one, a paradoxical iris. This one, the OI was known, the OI was diagnosed, treated. The patient, we saw that the patient was okay when it comes to the OI. But the moment we started the heart management, then the person deteriorates. Everything comes back. The OI that we thought we had treated will bounce back and the person immunity or the person deteriorates. So this is paradoxical. You are expecting the management to go well because you know that, oh, you are done with the management of the OI. Now you are free to initiate your heart. But unfortunately, it will not go that way. The OI or even other OIs that you thought you've managed will worsen and the person deteriorates. Either of these types could be life-threatening or mild, depending on the intensity of the immune response. As I said, the person can experience severe shock from the immune response and may not survive. At times, depending on the level of response, the reaction may be there, but it may not kill the patient. Any question here? Any question? So note that if a person comes with HIV, yes, diagnosed, look out for the possibility of existing OIs. If not, you could get the paradoxical one or the unmasking one. Either of them could either be mild or life-threatening. Now, this is how it goes, graphical representation. So for example, the first one, trying to explain paradoxical OI. So the person has new OI diagnosis. This one, you know, you've diagnosed the OI. Then you manage the OI. So the person started improving. And as I said, for TB, for example, after initiating the TB management, 2 weeks to 8 weeks time, you can initiate your highly active antiretroviral therapy. So you started, you are free to go, expecting that the person will get better. Only when the person's clinical situation begins to deteriorate. This is what is referred to as paradoxical iris. But at times, it may not be true paradoxical iris. It may also be due to other reasons. It's not all the time that when you clear the OI and then you start your heart and the person's system deteriorates, you always blame it on paradoxical iris. It could also be due to other possible reasons. And this could, for example, be due to the highly active antiretroviral agent or the agents that you are using to treat the OI, their toxicity. So it could be drug reactions that you are seeing, not actually the OI causing the iris to come in. Or there could even be drug resistance to the OI. You thought you have managed it, but along the line, the management did not go as planned, as in the OI. Then, of course, some of the bacteria or whatever infectious agent will persist. Then the reaction will occur. Or maybe due to poor adherence, and therefore the person is not getting the results from either the OI or the heart itself. Or there could even be a new OIs altogether because the treatment is not going well. When it comes to the unmasking, as I said, you didn't know that there was any OI. You did not know. It was hidden. And therefore, straight away, you initiate your highly active antiretroviral therapy. Unfortunately, iris sets in because the person has now regained immunity and there is an immune response against the hidden OI. Then you get several OIs even coming up, several problems. Here too, we could have other reasons. It's not always that it could be due to only unmasking iris. Obviously, it could be due to the mixed diagnosis that the patient suffered, or even a new OI altogether, which is coming in because the immunity is still down. But note that basically, for iris, you have two, paradoxical and unmasking. Unmasking, you didn't know that there was any or there were any kind of OIs. You started the treatment and deterioration occurs as a result of the immune response. Paradoxical, you diagnose the OI, you manage the OI thinking that, oh, you've been successful with it. So you are free to initiate your heart only for the person to deteriorate. This is paradoxical. It's not going as planned. Any question, class captain? Any question? So before you even think about managing the patient.
Hello, Doc.
Somebody. Yeah, hello.
Yeah, Doc. So with the final differential diagnosis for the unmaxing, are you saying that maybe after initiating the heart therapy, then along the during the course of treatment, the person gets an opportunistic infection?
Yes,
That,
you don't expect the person to get it because that is part of your goals. Once you are starting heart, you expect the person to get improved immunity and therefore no OIs. You get it?
yes, please. Thank you.
Because you think that the person is clean, there is no OI. Meanwhile, the thing was hidden. So it could be that it was hidden, you didn't know. Or it could even be a new one coming in. Either it was there or it's not coming in. Once you start your HIV drugs, you don't expect to see any OIs because the person should be improving immunologically. So when it comes in, then to be maybe something that was hidden somewhere that you missed the diagnosis, and therefore we term it as unmasked. So the reaction has helped us to notice that, oh, maybe there was an underlying or hidden OI that we could not diagnose, and therefore the inflammatory response has been mounted against that particular infectious agent. Any question again? Any question again? Class captain, are you there?
Yes, please.
Do you have any question?
No, please.
Right. Now, this is very common. You have so many people living with HIV who are co-infected with tuberculosis. And therefore, we normally mention TB and especially hepatitis B. These two conditions, normally, once you present with HIV, you'll be asked to do those additional labs to confirm TB, labs to confirm hepatitis, because they are very common with it. So many people have the infection, TB, but because our immunity is strong, the TB has become inactive, latent, dormant. Our immunity is suppressing it. So the moment you get HIV and with the time, maybe you don't intervene, then you drop to the A stage, then your immunity is down. That is when you realize that, yes, you've been having TB for a very long time. Just that your immunity was up there, the TB was suppressed. So today that your immunity is down, the TB will show you its true colors. And therefore, it's important that we talk about TB, especially the drugs that we use in the management of TB. They are likely to have a lot of interactions with the medicines that we use in the management of HIV. And now, as I said, for TB and HIV, for heart-naive individuals, those who have never been initiated on heart, when they come, don't rush. Once the TB is confirmed, start with the management of the TB. Normally, you do the 2 months intensive phase by using 4 drugs: rifampicin, isoniazid, paracetamide, and ethambutol. This is meant to drastically reduce the TB load, to improve the patient's health, and to prevent the spread of TB to others. That is why you are so aggressive in the 2 months intensive phase, using these 4 strong agents. Then, for the remaining months, which is 6 months, for people living with HIV, we do 8 months now. You are going to use the 2 main backbone agents for TB management, that is rifampicin and isoniazid. For normal people who don't have HIV, we do 6 months. That is 2 months intensive phase and 4 months continuous phase. Same strategy. 4 drugs for 2 months, then 2 drugs for 4 months. But in HIV, you do 2 months for 4 drugs and 6 months for 2 drugs. You can see rifampicin in red text, a very strong enzyme inducer, versus these HIV medicines. Some are strong inhibitors, some are strong inducers, and therefore you have a lot of interactions. But lucky for us, the HIV medicines have been carefully selected when it comes to those living with TB, such that the potential interactions that we know like they can happen are minimal, very, very minimal. Even when it may occur, the drugs are carefully chosen. And therefore, when they come, remember, you are always going to initiate the TB first. Then for 2 weeks to 8 weeks time, because of the fear of iris, you start 2 weeks to 8 weeks time. So by the time that the person regains immunity, then almost the first 2 months intensive phase is over. By that time, it's expected that the TB load will be so low, then we dodge iris. Carefully, we've selected the heart agent not to cause excessive interactions, to harm the patient, or to cause treatment failure because of drug-drug interactions. And therefore, in these individuals, drugs like tenofovir, lamivudine, or emtricitabine. Then preferably efavirenz is added. Remember, in the general population, dolutegravir plus the others will be first line. But because of the TB medicines, especially rifampicin, the first choice now becomes efavirenz. And if maybe efavirenz is contraindicated, for example, the person is presenting with some CNS problems already, maybe HIV encephalopathy, efavirenz will also have this kind of problems, and therefore you may want to dodge it. Then you can use dolutegravir in place of efavirenz. But note, even with dolutegravir, because of the enzyme induction effect of rifampicin, it can easily increase its clearance and therefore decrease its plasma concentrations below the therapeutic one that it may not work. And therefore, if you are doing dolutegravir in the presence of rifampicin, it is advised that you do upward dosage adjustment to dolutegravir. You add additional 50 milligrams to the normal dose, BD, so that it's like you are increasing the dose to cater for the possible losses from the rifampicin induced increased clearance of dolutegravir. Efavirenz can withstand the heat from rifampicin, but dolutegravir will not be able to withstand, and therefore you will have to add top up to make room or cater for the possible increased clearance. One may also decide to go for what is known as the triple nukes. Should in case any of the normal regimen for heart, you are expected to choose 2 drugs from the nucleoside, after which you will switch the patient to the normal regimen, 2 from the nucleoside/nucleotide group, and the third group or the third agent. You are expected to choose 2 drugs. So from the
Please, can you
nucleoside,
go over the triple nukes again? I'm so sorry.
choosing 3 drugs from the nucleoside from or the nucleotide reverse transcriptase group. That's not the normal thing we do. We are expected to choose 2 drugs. For normal heart therapy, you choose 2 drugs from the nucleoside/nucleotide reverse transcriptase group. And your third agent will be from the other group. But in TB HIV, there could be possibility of interactions plus other patient parameters that may not permit the use of the normal regimen like this, using a third agent from, say, the non-nucleoside group or the integrase group or even the protease inhibitors group. Maybe possibility of interactions, patient situations, so some of the medicines are contraindicated or what have you. If it happens in that manner, then you are allowed within that 8 months period when you are doing both the HIV and the TB, you are allowed to choose all your 3 from the nucleoside/nucleotide reverse transcriptase group. That is what we call triple nukes, choosing all the 3 drugs from one class. This is done only in HIV, TB. After the management of the TB, you switch the patient from the triple nukes to the normal regimen because the patient will be taking off the TB medicines, and therefore the fear of the interactions will not be there. So the patient can be put back on the normal regimen. So remember triple nukes, choosing all the 3 drugs from the nucleotide reverse transcriptase group, and you are free to go. As I said, you initiate your TB management, fear of iris. Then 2 weeks to 8 weeks time, you are free to start your heart. This is for heart naive patient. Heart naive patient, somebody who has never tasted heart before, presenting with an OI like TB and HIV. That is when you do this. But if the patient is a known HIV patient and has been on heart already, and this same patient presents with an OI, and of course, the HIV has been there. In this case, you don't do the treatment by starting with the OI, and then by 2 weeks' time to 8 weeks' time, you initiate your heart. No. In this patient, continue your heart and initiate the TB or the OI management at the same time, because in these individuals, the IRS will not happen. So that strategy is reserved. Delaying heart management is reserved for heart-naive patients. If the patient has been on heart already and still a stubborn OI comes in, don't stop your heart and start the OI management and then restart your heart 2 weeks to 8 weeks time. No, don't do that. Continue with your heart management and initiate the OI management at the same time, because in these individuals, the iris will not occur. Note the difference between the two, because that strategy that I've been mentioning is for heart-naive patients. For those who have been on heart, don't stop, continue and start your OI management. Any queries? Last captain.
No queries.
All right. So these are examples of OIs and the medicines or the strategies that we use in managing them. So in TB, of course, we mentioned them, and then the kind of OIs that we use. All these we've mentioned. Herpes simplex and zoster, very common conditions in HIV patients. Use aciclovir for herpes zoster and herpes simplex. You can also get eye infections from cytomegalovirus. So cytomegalovirus retinitis. In this case, we use IV injectables of ganciclovir for the management. When it comes to Kaposi sarcoma, which is some kind of cancer, then you use the anti-cancer agent, chemotherapy by using bleomycin, or a combination of radiotherapy and chemotherapy. So you use radiotherapy with vincristine. Toxoplasmosis could be very simple, very, very common. Parametamine is used in combination with sulfur diazine plus folinic acid. You could also straight away go and choose clindamycin, but that is reserved for severe cases. It looks like the first regimen is complex. Parametamine, sulfadiazine, plus folinic acid, complex regimen. Clindamycin, very simple, monotherapy, 600 milligrams, not even the normal 6 hourly. This time it is the 8 hourly. I would prefer that one. But note that clindamycin is reserved for severe cases.
Sir, please, the efavirenz, please, can you go over why the ART for the TB is efavirenz based first, unless there's a contraindication, then dolutegravir is used.
So efavirenz is not affected by the enzyme activation effect, and therefore the increased clearance effect of agents like rifampicin. It is not affected. So it can withstand it, and therefore, of course, note that for chemotherapy, therapeutic plasma concentrations is key. And therefore, if you are doing HIV management and you are being threatened with the possibility of reduced plasma concentrations, then obviously you are going to fail. So the last thing we want to experience is getting the concentration of the various drugs below the therapeutic plasma concentrations. By giving rifampicin, we have that threat. But lucky for us, efavirenz is able to withstand that. It's not affected. That is why it now becomes first line. Adding efavirenz to the others becomes first line when you are doing TB plus HIV. So in case you have contraindications to efavirenz for any reason, as I stated, CNS problems, it may be HIV encephalopathy or whatever, Efavirenz have that same side effect. And therefore, you may don't want to use efavirenz. Dolutegravir is an option. Though it is affected, but it is still used. So to make room for the possibility of increasing chelans that will reduce the plasma concentration, you top up the normal dose that you use, you add additional 50 milligram to the normal dose to cater for the increasing clearance that you are likely going to experience from rifampicin. And therefore, the 50, even if it's cleared, it will be remain with the normal concentration that will be created by the dose. So you won't fall below the required therapeutic concentration and it won't fail, it will work. But efavirenz is not affected. You don't need to top up its dose. If you use nevarapine, similar thing like what happens to dolutegravir occurs. And therefore, normally you need to top up. In children, normally you use additional 200 milligram per their body surface area to cater for the possibility of losses from the enzyme induction effect of rifampicin in red disc. Are you okay?
Yes, please. Thank you.
Right. So Kaposi sarcoma, then toxoplasmosis, as I said, clindamycin is an easy regimen. PJP, also very common. Pneumocystic Jerovici pneumonia is very common. And our good old cotrimoxazole is able to kill it. Pentamidine is another option that can do it. And to minimize the inflammation, you may add prednisolone to it. Diarrhea, in fact, chronic one, not acute diarrhea. In HIV, you normally have chronic diarrhea. Could also happen. And therefore, if it comes and it is non-bloody, normally possibility of OI is there, though non-bloody. Bloody is very serious. If it's non-bloody, then you can use cotrimoxazole. Depending on the patient, you can use cotrimoxazole. If the patient is G6PD positive, as in the person is having some defects, of course, you can use cotrimoxazole. Doxy, again, depending on the patient. PDX below 12 years, pregnant women, breastfeeding mothers, and what have you, you can use doxycycline. Note all these. Metronidazole is an option you can use. Then for strongyloids, you can use albendazole 400 milligram 12 hourly for 3 days. If it is bloody diarrhea, then you are going Cipro plus metronidazole. Cipro plus metronidazole. At times, you may not even have any infection, just that the person is running. That is when you go in with an anti-motility agent like loperamide. Candida infections representing fungal could be there, either topical or systemic. So if you have, for example, vulvovaginal candidiasis, that could be recurrent. And of course, for the recurrent one, you have to do the treatment for about 6 months. If you check from the BNF, they have about 3 different regimens. I remember one of them is when you use the pessaries for about 10 days. So if it's miconazole, you use miconazole for 10 good days. Then you can switch to oral fluconazole daily for 6 months. Or you switch back to once weekly miconazole for 6 months. Recurrent candidiasis, vulvovaginal candidiasis in HIV individuals, immunocompromised. But please check for the other 2. There are 3 separate regimens for recurrent candidiasis. You can check it from the BNF. Cryptococcal infections, very serious. This can give you meningitis. When it happens, then the use of amphotericin B with or without flucytosine is recommended as the start. The first 14 days, you are doing amphotericin B plus or minus flucytosine. After which you switch to fluconazole daily for 2 months, or you continue until you don't see any, or you don't isolate any of the fungus with cerebrospinal fluid sample. So the minimum is continue with fluconazole for 8 weeks, or at times you can get high load that by the 8 weeks time, you may still have some residues. So for the residual amount, then you have to continue and keep on checking the cerebrospinal fluid for existence of these fungus. So the person will continue the oral fluconazole until you get negative isolate when you check the cerebrospinal fluid. Any queries? Any queries? Class captain.
None,
All right.
please.
HIV is complex, very, very complex. And at times, unfortunately, some people can get exposure to the virus that maybe through their work, whether it's hookup or it's healthcare practice or whatever, or rape or what have you, you can get an exposure, or even from your mouth, vertical infections or vertical exposure, you can get exposure to the virus. If it happens, don't worry, there is a way out, because we have some regimen that can take care of your exposure called post-exposure prophylaxis. So you'll be exposed to the infection, but these drugs will not allow the life cycle to go on. And therefore, with time, the exposed CD4 cells will die out and die with the virus. And therefore, the disease will not get established. The virus will not be able to integrate itself into your genome and take over and cause the establishment of the infection. If this will be successful, it depends on the time that this prophylaxis is initiated. Preferably, after the exposure, within 1 to 2 hours, if you initiate this prophylaxis, that is the best. It doesn't work if you wait 3 days' time, then you begin, or 3 days is over and you begin. So preferably, the moment you know that you have engaged yourself in a risky match, maybe you went to a doom for one quick match, then unlucky for you, you get a tear of rubber. Straight away, you pick a taxi to Confanoche, then you report yourself. I've engaged myself in a risky match, so please help me. That one from Edum to Confanoche, about 5 minutes or so. Very good. When they initiate, you get better control. But if you go back to your house and you sleep after 72 hours, and then somebody tells you there is this strategy, you come back. We may initiate, but the probability of you getting the infection becomes high and it may fail. So always try and start. If per the exposure, it demands that you should be given the prophylaxis, it is preferred that you start within 1 to 2 hours. After 72 hours, it may not work. Now, as I said, depending on the level of exposure, you may be treated or not. And therefore, the risk involved in getting the infection after the exposure has been categorized into 3. We have very low risk, and high risk, depending on the exposure. Now, very low risk means, yes, there is a risk, but very, very low. This is when the person gets an exposure to a potentially infectious agent, material, any sample on your skin while your skin is intact. You don't have any breaks in your skin, any sore, no wound. It's coming from maybe an HIV positive patient. The person has the HIV well controlled. For example, even the person's HIV is undetectable. and maybe you get some splash of this person's blood on your skin while your skin is intact. With this one, it is termed as a very low risk. So you shouldn't start crying. Then low risk is when you get an exposure to a very small volume of blood or any other body fluid that is known to contain the virus, semen, vaginal secretions, breast milk. These are all body fluids that contains the virus, blood, semen, vaginal secretions, breast milk. So once you get an exposure to a very small volume to any of these fluids, or maybe you get a needle prick, and the needle is not the one that has a hole in it to accommodate high amount of the fluid. In this case, then we say that you are having a very low risk. Or when even there is an injury, but the injury is restricted to cutaneous membranes, it's not a deep cut. In this case, we say that it is a low risk. High risk, of course, we all know. Exposure to high volumes of fluid samples containing high levels of the virus. Normally, during the seroconversion stage or the A stage, these individuals do have high viral loads. And if you are unlucky and at this level, you get an exposure to such fluids, especially when maybe you have some injury to the part that was exposed, then you are in trouble. Imagine getting a needle prick and the needle contains a hole that is harboring high levels of any of these fluids from somebody having even resistant virus, high load, then you are in trouble. If you get a very deep cut from an instrument that has been used on these individuals, maybe intra during surgery, then you get deep cut from using a machine or any instrument on HIV patients, especially those with high loads, then you are in trouble. In this case, we say that you have a high risk exposure. Therefore, according to the level of exposure, we have different management strategies. If it is very low risk, then no cause for alarm. Intact skin, small volume of this fluid. Just wash the exposed area with soap and water. Wash it very well to clear the fluid or whatever, and of course, the virus. If it is low risk, then of course, the risk becomes high. You must start your antiretroviral agent for prophylaxis. In this case, we are using a dual therapy of, for example, zidovudin and lamivudin. The combination is called Combiver. So you do it, remember, you are starting within 1 to 2 hours. If you miss this, don't let it go past 72 hours. So you initiate for 28 days, which is 4 weeks. If it is the high risk type, and of course, you manage it as if you are doing proper treatment. Triple therapy, no room for mono or dual therapy. So you are using a combination of zidovudin, lamivudin, and a boosted protease. For example, ritonavir boosted lopinavir. This comes in even at second line. When you are doing your normal regimen, this is reserved from second line. It's not even part of first line. When somebody has failed first line, you are going second line, then this combination becomes an option. It means that per this level of exposure, we have a serious case, and therefore we must be aggressive. If not, the condition may establish. Use Combiver plus a boosted protease for the effect. Any question?
Hello,
Any
Doc.
question?
Hello, Doc.
Yes, sir.
So
Yeah.
in the advent of rape, would we always assume that the rapist is HIV positive? Therefore, we have to initiate post-exposure prophylaxis.
Straight away. Until it is established that the culprit is negative. Of course, For a rapist, he will even run away. So where are you even going to get him to do the test? So in order not to create any problems, once the person reports that he has been raped, test him. Yes, wait. There is this also that you need to know. For all you know, even the one who has been exposed will even have the infection already. So when the person comes in for post-exposure prophylaxis, it is also important to test the person before you initiate. So one of the things that you do before initiation is to confirm whether the one with the exposure already has the infection or not. If you already has the infection, then there is no need for any prophylaxis. You already have it, and therefore we initiate the processes involved, the counseling and whatever, and then later on, if everything is okay, we initiate the heart. So when you come and then we do the test and you are negative, then we start the prophylaxis. Until maybe we get the one who did the rape, that stubborn guy, and then we test and realize that the person is negative. Then you may stop. You won't get to the 28 days. On the ward, as in the clinical setting, if let's say you don't know the HIV status and you get a needle prick from any patient, quickly you go and report at the pharmacy for the initiation. Of course, you, the healthcare worker, will also be tested to know whether you already have it or not. If you don't have it, then they initiate the post-exposure prophylaxis. Then they test the patient. And if the patient is negative, then there will be no need for you to continue. We don't want the 72 hours to be over. And preferably, we want to initiate the thing within 1 to 2 hours. So that is how you do it. The person with the exposure will be tested. If the person is negative, then we initiate the prophylaxis. If the person is positive, then we activate the protocol, the counseling, the whatever, and what have you. Then we start full treatment. You already have it, then you don't need any prophylaxis. Are you okay?
Yes, please.
All right. Any other question? Okay, fine. Then there are some situations where you can even get the thing, you know that there is high possibility that you get the exposure. So you want to arm yourself so that should in case you get the exposure, there will be no fears. For example, in HIV discordant couples is when one is positive and one is negative. So once you still have the VIM and you want to stay with this person, of course, matches will occur. And therefore, there is a high potential that you may get the infection. So the one who doesn't have the infection yet can decide to go for prophylaxis. This is an example of pre-exposure prophylaxis. If you are a hookup person, either male hookup or female hookup, because of the nature of your job, you are just firing everywhere once they give you cash. Then there is high possibility for you to meet your match one day. High risk. And therefore, before you even get the exposure, you also qualified for pre-exposure prophylaxis. All these individuals. So anybody who thinks that he is at high risk of getting the exposed, as in the exposure, may go for pre-exposure prophylaxis. Common examples, technically, HIV discordant couples. One is positive, one is negative. Then, of course, the one who is negative can start taking these pre-exposure prophylaxis. If you have a job like hookup, locally known as Ashawo, either male Ashawo or female Ashawo, accepted, no problem. In Ghana, though, Ashawo is illegal. You can start with this prophylaxis because you know that your job is dangerous. Examples include daily intake of either oral tenofovir or emtricitabine. you take it daily, or you know that it's just like you are preventing pregnancy with contraceptives. You know that you are at high risk. And then for ladies, we have additional vaginal agents for them. Dapivarine, which is a non-nucleoside reverse transcriptase, vaginal ring that they can put in there so that when the semen is coming, it won't be like you are killing only the sperm. You are also killing the possibility of any virus in there. You've armed yourself already, red alert. So any incoming threat will be neutralized by the pre-exposure prophylaxis. Any question? Any question? Last captain, free to proceed.
Doc, please, is it like always certain that they will be protected?
No, this is not
Especially
100%. This is not 100%. Even the post-exposure to is not 100%. We may initiate within even 30 seconds, not even 1 minute. And if you are not lucky, it may still fail. But there is high probability that if you do so, you won't get the condition. So both pre and post-exposure, they are not 100%, no. So if you are going for any of them, then you have to know this. It's not 100%. So that if it fails, then you blame your house people that they are doing you. Are you okay?
yes, please.
Hello,
All right.
doctor, please.
Doctor,
The
doctor.
please the P variant. When they wear it, are they supposed the females can they also wear female condoms? Or can the other person also wear a condom? Or
Oh
it's
yes,
just
it's just like
the ring?
IUD. It's just like IUD. The
Ah,
way they
okay.
place it. So you can do your normal things. Can do your. In Ghana, do we still even have these female condoms? I don't see them around.
Yeah, I
They-
haven't seen some in a long time.
yes. People don't. Yeah, they don't even condoms. Nowadays, they've started buying it, not for HIV though, but for fear of pregnancy. That is the main issue. They don't fear as in HIV. Until you get a condition, you don't fear. You fear pregnancy more than HIV. But the female condoms, no. If you sell them, I think
Yes,
they
please.
get expired. People don't buy them. Okay, all right. So, Saptrin, you are saying that in HIV, your immunity goes down, especially when you did not know, and then you begin having OIs. Then, of course, there is one single agent that has a very broad spectrum, wide spectrum. It can fire protozoas, fungals, bacteria, and what have you. Because all these pathogens, their survival depends on protein synthesis. And any agent that interfere with protein synthesis, it doesn't matter the type of microbe, can easily control. And therefore, looking at the active agent in cotrimoxazole, that is sulfur methoxazole and trimethoprim, you are blocking the folic acid metabolic pathway, both upstream and downstream in these microbes. And therefore, it is not surprising that cotrimoxazole is very strong and has a wide spectrum against all these agents. And these are normally the agents implicated in OIs when it comes to HIV, bacteria, fungal, protozoa infection. Don't forget that you can also get viral infections, but virals don't go by that pathway. But at least these three, cotrimoxazole, can cover you. Once you give it, then it improves the person's chances when it comes to morbidity and mortality. You normally don't have appearance of WHO grade 3 and grade 4 issues when you are on cotrimoxazole in HIV. So it's very good. Again, you'll be thinking about, why am I going to take all these HIV medicines plus Septrin again every day till my immunity comes back? It has been proven that the pill burden versus the benefit outweighs the pill burden. Therefore, Septrin use in HIV patients, especially those with immunocompromised states, is very, very, very helpful. If you don't have any contraindications, then Septrin is the way to go. If you are pregnant with HIV and reduce immunity, remember, after quickening, in pregnancy, you start your anti-malaria prophylaxis. Your anti-malaria prophylaxis, the so-called intermittent preventive therapy. If you are on Septrin, there is no need for you to do the intermittent preventive therapy with sulfadoxine and parametamine. Malaria parasites are protozoans. Septrin will take care of that. So do not combine Septrin and SP at the same time. If you're on Septrin. Yeah, hello? Hello?
So we cannot hear you.
Oh, okay. So I'm saying that Septrin has a wide or broad spectrum of activity against a variety of microbes, bacteria, fungi, and protozoa, simply because of its mechanism of action, blocking folic acid metabolic pathway and therefore protein synthesis in these microbes. And therefore, it is very, very helpful when it comes to HIV immunocompromised state. It has been found to improve mortality and morbidity. And again, the benefit outweighs the pill burden of taking this prophylactic Septrin together with HIV medicines and even several other medicines. And therefore, it is very good that you use it. But in pregnancy plus HIV, you know that in pregnancy after quickening, which is the 16-week gestational period, you are to initiate your intermittent preventive therapy, malaria. If you are on Septrin, you don't have to do this intermittent preventive therapy with SP. You don't have to do that because Septrin can take care of protozoas, of which your malaria parasites are part. And therefore, don't do intermittent preventive therapy in pregnancy whilst you are on cotrimazole therapy. It's kind of a duplication of therapy, which is a care issue. Are we okay? Now, before you start your Septrin, you will have to consider whether you qualify to take or not. Obviously, if you are a G6PDD, you can't take it because you are going to be in trouble. If you are a G6PDD, you can't take it. You are going to have a lot of hemolysis. So you are not expected to take it. Not that alone. In adults, if your CD4 count is below 350, then you have to take it. You have to take it. You qualify to take it. Or maybe you have a WHO stage 3-4 OI setting in, then you have to take it. Of course, since malaria, they belong to the protozoa group. If you are in areas like Ghana and the other African countries that these infections are endemic, of course, then you have to put you on. If not, you get malaria and HIV and it may push you to your grave. So these are some of the things that you have to do. Key populations that we don't joke with them when it comes to Septrin: infants, children, and adolescents with HIV. It doesn't matter their immunity. This category of individuals, especially those younger than 5 years, is a goal. You have to give them Septrin prophylaxis until their immunity improves. So all these people, they are expected to be given. G6PD don't. When do you stop taking Septrin? It's not one of the drugs that you are going to take for life. No. You are only taking it at the time that the person's immunity is low to prevent OIs. So at some point, you will stop. So, for example, in adults who now become clinically stable whilst they are on heart therapy, and of course, we have evidence that they've recovered, their immunity is intact, and evidence of viral suppression is available. The viral load has decreased, even to levels that we don't fear, say undetectable limits. In that point or at that point, the person's immunity is back, and there is no need for the person to continue taking Septrin. Though we know that the benefit outweighs the pill burden, but once the person's immunity is back, you don't need to take it. For HIV exposed infants, maybe when your mother was pregnant, you were in the uterus, your mother had the infections. If it is confirmed that the baby, after coming, is HIV negative, then there's no need to continue the HIV medicines, provided breastfeeding is also stopped. Remember, breast milk contains the HIV virus. So if breastfeeding is stopped, then by say 18 months, we use serology to confirm that, yes, this baby is negative. Then at that point or beyond that point, there is no need to continue the Septrin prophylaxis. So for adults, once you regain your immunity with evidence, for example, viral suppression, no OIs again, then you can stop. For infants or babies who are exposed, provided breastfeeding is stopped, management of the TB, and it is confirmed that they are negative, and there is no need to continue. You have to. Any question? Any question? Any question? Class captain.
No, please.
All right. Again, as I said, TB is very common in HIV individuals, people living with HIV. And now, as part of the management of TB or HIV infections, put it that way, it is recommended that we do what we provided TB preventive therapy. Others call it PTP. PTP. You do TB preventive therapy. So once the person comes with HIV, we know that there is high potential of active TB, very common. And therefore, per the current protocol, you have to do this prophylactic or preventive TB management. But to be
Hello, Doc.
yeah, hello.
Please, your line was breaking.
Oh, sorry. So is it clear now?
Yes, please.
Okay. So with people living with HIV nowadays, the management protocol has it that since TB is very common in these individuals, you don't wait. Or if you have TB, then of course we will check whether you are HIV positive. But once you have the HIV, even if you check and you are negative, you still has the high chance of getting the TB with the HIV. And therefore, it is important that we cover you from getting the TB. So to start, once you have or you present with HIV, you should be tested for the presence of TB because we are going to initiate. And the kind of medicines that we use for the TB prevention therapy is not the same as the kind of medicines that we use for the treatment of TB proper. But when the TB is established, we are doing combination therapies, 4 drugs for the 2 months intensive phase, and for example, 2 drugs for the 6 months continuous phase. The prophylaxis is not like that. You may be using just 2 drugs or even 1 drug. And therefore, we don't want any resistance to set in, should in case you already have the TB. So we use Gene Expert to confirm whether you have TB or not when you present with HIV. The Gene Expert is able to detect the presence of TB And in addition, even tell us whether you are resistant to rifampicin, one of the backbone medicines used in TB management, together with isoniazid. These two are key. But the gene expert is able to detect the TB and even tell us the level of resistance when it comes to rifampicin in particular. Then we even confirm with radiology, X-ray, so that from that we can know whether you are truly positive or negative for TB. If you are negative, then you qualify for the TB preventive therapy. If you are positive, then of course we are going to manage you proper. So this is now part of the management of HIV, preventive TB therapy. Note, how do we do it? How do we do this? So there are two options, but currently the dual option is what everybody is doing. But remember that we also have the monotherapy isoniazid that you are going to take for 6 months. Isoniazid that you take for 6 months. But the combination of rifampicin and isoniazid on weekly basis for 3 months is now the common PTP strategy. That is what we do. So you do a combination of rifampicin and isoniazid. For children, you are doing isoniazid and rifampicin daily for 3 months. Don't forget the neuropathy of isoniazid, and therefore the addition of pyridoxine to try and prevent peripheral neuropathy is also recommended when you are doing PTP. So this is the regimen. So it is either you are going for the monotherapy, which is not common nowadays. It is rather the combination therapy that we do. So if you are doing isoniazid, is daily dose for 6 months. So these are the doses. Then you are doing the most common preventive strategy nowadays, rifampicin and isoniazid. You do it once a week for 3 months. This is to prevent TB in HIV individuals. Nowadays, that is the way to go. Any queries? Any queries? Vice Captain.
Hello, sir. Please, could you
Vice
go back?
Captain.
Hello,
Yeah, hello.
sir. Please, could you go back to the previous slide? Okay. Thank you very much.
All right. I sent your slides last week. I think the duration for TB, you need to correct it. In the previous slide, it used to be the normal one, 2 months intensive phase and 4 months continuous phase. It's now 6 months intensive phase. So please remember and then correct the TB management in people with HIV. The continuous phase is still, the intensive phase is still 2 months, but the continuous phase is not 4 months anymore. It's 6 months, a total of 8 months. 2 months intensive phase, 6 months continuous phase for the management of an established case of TB in individuals living with HIV. All right. Now, we are here. What are we doing? Elsewhere, people are trying to do new things. Every day you take medicines. Previously, you used to take about 12 tablets of antiretroviral medicines. Nowadays, you can even take 1 or 2 the whole day. Then you are free to go. But people are even thinking about doing injections once a month, once every 6 months, or even once within 10 years, so that when you get your shot, you won't be going to the hospital with all this risk of somebody seeing you and discriminating against you. So elsewhere, not here, we are not doing anything. The current trend has it that, for example, in the US, they've now approved injectables. For example, Cabinova injectable. This is a pack of 2 different medicines. So 1 pack, but 2 different vials in it. One of the components is cabotegravir, which is an integrase inhibitor, and the other agent is repivirine, which is a non-nucleoside reverse transcriptase inhibitors. You use these agents and you get the injection once every month. You get the injection once every month and you are covered. This is what is going on. Elsewhere, they even have agents like ibalizumab that you take and it will cover you for every 2 weeks. This is okay for HIV-1 infections, but not 2. So very soon, if you are lucky, you may even get drugs that you go for injections once a year or once every 10 years, and you are good to go. So note that this is happening elsewhere, but in Ghana, we don't have this yet. We do not have this yet. Now, counseling is very important when it comes to heart management. Very, very, very important. So if you are doing counseling on heart, maybe before you even initiate the heart, there are key things that you need to inform the patient. Let the patient know that this is the situation. Don't lie to the patient. Do not massage anything, but don't scare the patient too. Let the patient know that the heart will not cure the condition. And therefore, the patient is taking the drug all through. It's a lifelong therapy. It manages the thing. It doesn't allow the viral load to go high, but it will not clear. It's not like malaria that you can cure. Let the person understand so that the person will appreciate why he or she will have to take the drug for life. Let the person also understand that he or she can infect the partner or partners. And therefore, there is the need to stop firing around left, right, center. He himself or the person with the HIV can even get other HIV from infected persons with resistant strains. And therefore, he is still not safe. Even the one that has been diagnosed is still not safe, so that they don't begin to spread the thing across. Of course, there are financial considerations. Normally, these individuals, they are sick, they can't work. So though as a health worker, you can't help the person financially, but there could be some NGOs or associations that are ready to let the person know all these benefits. Maybe he or she join those associations for help. Drug information, pharmacists is very, very important. The patient, how to take the medicines, expected side effect, what to do if any of these side effect occurs. All these things are very, very important as part of the counseling, and the need for strict adherence. Strict adherence. For the management to be successful, strict adherence is very important. There is no way to joke when it comes to HIV medicines. I'm taking it today, tomorrow I won't take, I don't like this color of tablet, blah, 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 blah. No. Then it has also been established that if the person is able to get a mentor or a monitor and disclose to this person that is HIV positive, and that person accepts to help monitor the person when it comes to adherence, it improves the person's status a lot. But still, people don't trust. In Ghana, you can't trust people. The person that you think you trust, you'll be shocked. You go and spread the news that you are HIV positive. So we still have problems with this monitor issue. But those who are able to get correct monitors, it helps when it comes to their management. Then, of course, once you have the infection, the emotional aspect and the social aspect, should in case people get to know the discrimination and all those things. All these things, you need to counsel the patient on them, prepare the patient mind towards all these, because all these are possibilities. Challenges in HIV management. Of course, stigma. Yes. Once people get to know, even your hand shape, they won't shake. You go to church, where you sit, nobody will sit there. Nowadays, when you are going to marry somebody, you are asked by the church elders to go and do some tests, one of which will be what? HIV. Once the church elder gets to know that you are HIV positive, and he finds out that by the time church closes, you are chatting with the daughter, you are in trouble. The way he or she will come and then take the daughter and he must say, be careful. He will by all means tell the daughter that this guy is HIV positive because that person is his or her child. All these stigma issues becomes challenges. And of course, if that is the case, then I'm not going to pick any monitor. I'll keep it to myself, not even my partner. You have a lot of people who their partners don't know that they are HIV positive. They stay in Accra, they come for their medicines in Kumasi. So and the drugs can be prescribed for like 3 months, 6 months. So once in every 6 months, if he tells you that he's going to Kumasi for some rounds and return the same day, you wouldn't know. You wouldn't know. This is because of the stigma issues. Another challenge is loss to follow up. Now, managing somebody, you think you've achieved steady state, everything is going on well, the person will not come again. The person will not come, go and follow herbal medicines. The person will decide to stop coming to your end because he has met somebody that he knows. So you go to another facility, you won't even tell them that he has been coming to maybe Confanoche, and the person is registered again as a whole new case, knowing that he has been on it. So there will be duplicate. So when it comes to statistics, instead of us getting 1, we are getting 2, always bloating the figures. All these becomes issues. And obviously, taking medicines every day is no joke. So pill burden, which of course will affect adherence, is also part of the challenges. With effective counseling, these challenges, you can't maybe clear all of them, but you may be able to control a high section of it. As a pharmacist, what is therefore our role? What do we do when it comes to HIV medicines? Of course, we can also provide adherence counseling to heart management. We can do it. When it comes to safe sex, you can educate people on that. Making the drugs available, logistics and everything, drug information, everything. When it comes to pre and post exposure, it is at the pharmacy that we do it. So post exposure prophylaxis services is done at the pharmacy. You can also advise people or even take part in voluntary testing and counseling. If you go to the peripheral hospitals, some of these things are done by pharmacists. They control HIV, almost everything, even initiating patients on it, everything. They do it. The pharmacist will do it. Any queries? Any queries? Ask Captain.
No queries.
Okay. So in conclusion, note that HIV is not your death sentence. Once you get it, no shake. The heart is always available. Just report. They will enroll you on heart, and your life will not be the same. Look at this man here, emaciated, but now he's laughing with a child. So HIV is definitely not a death sentence. There is hope. So this brings us to the end of our HIV. We still have some time. It's about, we have about 15 minutes to 11. Class captain, what do you suggest? Do we go for break and start another topic? Or we close for today and come back next week?
Doc, please, I'll find out from. Hello, Doc.
Yeah, hello.
Please, can I ask the class to
Yes, yeah,
tell
that's
us what
important.
they?
Yeah, please discuss
what
with
they
them.
want.
So I'll be here. If we are to continue, go for a break and continue, then we can start, maybe do the introduction of TB. Because once we are done with HIV, we need to start TB proper. If you want us to come back next week and do it too, fine. I'm cool with that. So I'll be waiting.
Uh,
All right.
yes, please.
All right.
Hello class, please type what you want on the group page. Majority or when. Thank you. Hello, Doc.
Yeah, hello.
Yes, please. Please, majority voted for next week, God willing. So we would
Next week. Okay.
appreciate it if we could continue
All right.
next week, God willing.
All right.
Okay.
Okay. So
Thank you
next week
very
you
much.
can. All right. You're welcome.
Yes, please.
All right.